really neat to see the, the addition now of shear wave elastography to EUS, and just adds into the armamentarium for endo, hepatic work. So let's switch over now to Jason Samarasena, who is also with you. And I don't know if he's just going to appear on the same screen or if Jason's in his office somewhere, but I think we'll be switching over to Jason on Zoom as well.
Well, my name is Jason Samarasena. I'm an interventional gastroenterologist at UC Irvine Health, and it's my pleasure to follow Dr. Chang and keep on the theme of endohepatology, really one of the, I think, most exciting areas in interventional GI and even hepatology. And I'm going to show you something that I think gives some credibility to that statement. But EUS-Guided portal systemic pressure gradient measurement is really my topic for today. And the next 20 minutes, I'll be able to hopefully give you a little flavor of the history of how this was developed, and proud to say that a lot of this technology was developed here at UC Irvine, and where we are, along this journey. These are my disclosures. There are 1.5 billion cases of chronic liver disease globally, and patients with cirrhosis transition through compensated to decompensated stages. And portal hypertension really marks that transition to decompensation. And the hepatic venous pressure gradient, or the portosystemic gradient, has been really regarded as the single best prognostic factor in liver disease, because it accurately reflects the degree of portal hypertension, or so we believe. And as a patient progresses in their pre-cirrhotic phase toward cirrhosis, we do a lot of things to understand that process and where patients are. We do biochemical testing, we do imaging, we do elastography, and then we do more invasive things like interventional radiology guided portal pressure measurements. The current standard for measurement is the HVPG, and it's performed by interventional radiology by a transjugular approach. So because you're cutting in the skin, it is a little bit invasive. But essentially what's happening is, through the internal jugular, you're floating a catheter over a wire, and that's a balloon catheter. And when that balloon is deflated, you're getting a free hepatic venous pressure. And that's an accurate, direct reflection of the pressure in the hepatic vein. And then when the balloon is inflated, you're getting a wedged hepatic venous pressure, which is an indirect measurement of the portal venous pressure. So the disadvantages of this are, yes, it is invasive because you're cutting on the skin. It uses ionizing radiation, but this indirect measurement of the portal venous pressure may be the biggest disadvantage, as I'll show you a little bit later. So a lot of interest, because we look at the liver literally every day. We see these vessels every day. Why can't we find a way to measure the pressure in these vessels? And that's what I'm so proud to say that under the direction of Dr. Chang, we were able to do. We were able to develop an EUS-guided portal pressure gradient measurement system using a 25 gauge FNA needle and a compact manometer. And we started this journey in the animal lab in a porcine model. And what you're seeing here on the left frame is a fluoroscopic image of the echoendoscope with the needle in the right hepatic vein of a pig. And our interventional radiology colleague has their balloon catheter in exactly the same place. And what you're seeing on the right frame is the endoscopic ultrasound correlate of the same thing. And what we were able to find is that there was just an incredible correlation between the transjugular measurements and the EUS-guided measurements, with an R value of 0.985. This is what the setup looked like. This is a traditional 25 gauge FNA needle. This is some non-compressible tubing that will attach to the needle. This is what the compact manometer looks like, and some heparinized saline. And so to kind of put this together, we attach the non-compressible tubing to the manometer. We attach the heparinized saline to the manometer. and then you attach the compressible tubing to the inlet of the FNA needle. And the pressure readings are done at the mid-axillary line to maintain with the phlebistatic axis. Now, when we do this measurement, we are going through the stomach wall. So it's a transgastric puncture. We're going through parenchyma and then going into the hepatic vein. So it's a transgastric, transparenchymal puncture of the hepatic vein. With the portal vein, it's the same thing. It's a transgastric, transparenchymal puncture of the portal vein. In some of the original work done in this area, transduodenal approach was used. Sometimes you were not going through parenchyma, and I think that may have been one of the reasons why there was complications in the early work in this area. This is a video showing the transgastric transparenchymal approach, puncturing the middle hepatic vein. And so what you'll see here is you can see the needle in the hepatic vein. We're going to flush with a little bit of the heparinized saline. You usually see some bubbles, sort of confirming good placement. What will happen on the manometer is the numbers will go very, very high, and then they'll slowly come down, and they'll level off. And then when it does level off, that number will be recorded as the number for that particular reading. And we'll repeat this 2 more times to get an average of 3 numbers in the hepatic vein. In this case, you can see the hepatic vein reading was 12. We're going to do the same thing, transgastric transparenchymal puncture with a 25 gauge needle into the portal vein. Usually it's the left portal that we try to target. And in this case, we do the same approach, 3 readings, an average. In this case, the portal venous average was 26. The hepatic vein average was 12. So the portosystemic gradient was 14 in this case, which, as you know, is elevated. Now, with chronic liver disease, I think the current standard or the current non-invasive measures, including transient elastography, I think does a fairly good job in categorizing the normal low-risk patients and then maybe the really sicker patients. But then there's this group sort of in the middle where there may be some discordant results, and we're really not sure kind of what is happening. And this may be a key area for us to explore in this continuum. And our task was really to see if EUS, portal pressure gradient measurement, could fill that role. This is a presentation that we presented at DDW in the AASLD section. It was an oral presentation titled Prediction of Liver Histology and Clinical Parameters of Liver Disease Using EUS-Guided Portosystemic Pressure Gradient Measurement, Results from a US Multicenter Endohepatology Experience. This is the largest study on portal pressure gradient measurement to date, and I was really delighted. Mark Moniquez, our superb advanced fellow, just did a wonderful job presenting this, and it was awarded one of the Best of DDW awards. And really proud to say that, because when we started talking with the hepatologists about this concept, the response was certainly not what we received at DDW this year. So our aims were to evaluate a correlation between EUS-PBG and clinical markers of portal hypertension, as well as non-invasive markers of liver disease and liver histology. Also, we wanted to determine the ability of EUS-PBG to diagnose chronic liver disease in these equivocal clinical situations that I just brought up. This was a multi-center retrospective study. Patient inclusion was from January 2020 to December 21, so almost 2 years of data. Patient demographics, liver disease, severity, non-invasive markers of liver disease, including the APRI score, the FIB-4, and the MELD. Transient elastography and liver histology data were included if they were available. And then EUS-PBG gradients of greater than 5 and greater than 10 were compared against these non-invasive markers and liver histology. Univariate logistic and linear regression models were performed. Our results, we had 159 patients in this cohort. The mean age was 56. It was a pretty even mix of men and women. And most of our patients were child class A, but we did have about 20% that were B and C. About a quarter of patients had varices and had portal hypertensive gastropathy. And we did have about 42% of patients with an elevated PPG, and about 20% had a significantly elevated PPG. We had patients, about 75% of the patients had stage 3 and 4 disease on elastography, and about 20% had histology with stage greater than 3. There were a number of indications why these patients were being evaluated, and not all patients were getting liver biopsies, getting transient elastography, getting portal pressure, but the indications for the reason why they were getting these evaluations were listed here. When we looked at comparing EUS PPG with clinical parameters, the common clinical parameters that we think about with associating with portal hypertension cirrhosis, there was elevated portal pressure in patients with thrombocytopenia as opposed to not, elevated pressures in patients with esophageal varices as compared to patients without, elevated pressures in patients with portal hypertensive gastropathy versus patients without, as you'd expect. When we looked at the portal pressure gradient as compared to the FIB-4, patients with a gradient greater than 5 had a higher FIB-4 score than patients without, with a gradient less than 5. And the same was true for patients with a gradient greater than 10 and less than 10. The same was true for the APRI score, with a pressure gradient greater than 5 versus less than 5, and the pressure gradient greater than 10 and less than 10. With the MEL score, again, we found the same result. If the patient had a pressure gradient greater than 5 versus less than 5, the MEL score was higher. And the same was true for the gradient greater than 10 and less than 10. Now, the correlations sort of broke down a little bit when we looked at portal pressure gradient with transient elastography. And we found that pressure gradient greater than 5 versus less than 5 didn't correlate as well with transient elastography numbers, both with gradient of greater than 5 and also with a gradient greater than 10. When we looked at logistic regression, the values that were associated with higher PPGs greater than 5 were thrombocytopenia, esophageal varices, portal hypertensive gastropathy, advanced liver disease based on fibrosis scores on biopsy. Again, the transient elastography didn't fall into the model, and a MEL score greater than 12 did as well. And the same essentially was true for a portal pressure gradient greater than 10. One of the interesting things that we were able to tease out from the data was there were patients that had grade 3 or 4 histology, but when we looked at the non-invasive measures, there was actually no evidence that they had this degree of fibrosis. Patients had no varices, no portal hypertensive gastropathy, no thrombocytopenia. The APRI score and the FIB-4 were low. The MEL score was low. Even the transient elastography didn't reflect the degree of true fibrosis seen on biopsy. But in these cases, the portal pressures were actually elevated. And so this was sort of a clue that maybe the portal pressure is one of the more sensitive markers of advanced fibrosis. With regards to procedural outcomes, there was technical success in over 90% of the 159 patients, and there were 2 episodes of bleeding that were self-limited. The patient was hospitalized, and there was no transfusion or extended hospitalization needed. Getting back to the EUS-PBG and elastography agreement, when we looked at comparing the liver histology with the portal pressure gradient measurement and the liver histology and the elastography, we found that in 53% of patients, the PBG and the transient elastography agreed with the liver biopsy. But in 45% of patients, it was only the PPG that agreed and the transient elastography was wrong. And in 2% of patients, the transient elastography was correct and correlated while the PPG didn't. So overall, there was a 98% correlation of portal pressure gradient with the liver histology. So our study conclusion was that EUS demonstrated a high correlation with non-invasive testing and histology. Higher PPG values accurately reflected more advanced diseases, advanced stage disease. There seemed to be a poor correlation of transient elastography and PPG in our cohort. But in a subset of patients, PPG did appear to help accurately predict disease stage. Now, just sort of getting back to the current standard for portosystemic pressure gradient measurements, which is the HVPG, and this issue of indirect measurements of the portal venous pressure. There's a lot of agreement amongst hepatologists that the HVPG really doesn't do a very good job with pre-sinusoidal portal hypertension. And these could be causes like early primary biliary cirrhosis, sarcoidosis, schistosomiasis. But maybe a more relevant question is, how well does HVPG do with NASH cirrhosis? Because this is really one of the most common reasons why we're seeing liver disease patients today. And if you look at this outcome study, HVPG is being called into question as a reliable measurement of portal hypertension. Liver biopsies and HVPG measurements were collected at screening and at year 1 and year 2. And during follow-up, 50 of the 258 patients with compensated cirrhosis experienced some liver-related clinical decompensation. That could be ascites development, hepatic encephalopathy, newly diagnosed varices, variceal bleed, a greater than 2-point increase in the Child-Pugh score, or greater than 15 on the MEL score. And interestingly, 14% of patients who developed a clinical event had an HVPG that was less than 10 within 4 months prior to the event. So it sort of makes you wonder if the HVPG measurement in this cohort of NASH-related cirrhosis might be underestimating the degree of portal hypertension. And so this is a more recent study that really looked at this carefully. And what has been established fairly well now is that the wedged hepatic venous pressure, that's the indirect measurement of the portal venous pressure, does actually accurately estimate portal pressure in alcohol and viral hepatitis-related cirrhosis. But whether this is, again, holding true for NASH cirrhosis is a little unknown. So the aim of this study was to evaluate the agreement of this wedged hepatic venous pressure and the true direct portal venous pressure in patients with NASH versus patients in a control group that were made up of alcohol and HCV-related cirrhosis. And the way they did this was they did this at the time of a TIPS procedure. So with the TIPS procedure, they were able to get the wedged hepatic venous pressure. Again, that's our indirect measurement. Then in the process of doing a TIPS, you have a curved, stiff catheter needle that you can advance and make communication with the left portal vein. Over that catheter, you can run over that needle, you can run a catheter. And then at the point that the catheter is in the portal venous, in the portal vein, you can get it now a direct measurement. So you've started with your indirect measurement with your wedged hepatic venous pressure, and now before you place the stent of the TIPS, you can get a direct measurement in the portal vein and then place the stent. And so what they found was in the NASH group, there was actually disagreement between the wedged hepatic venous pressure and the portal pressure more frequently than in the control group. 37.5% discrepancy versus 14% discrepancy, and this was mainly due to an underestimation. So this study concluded that in patients with decompensated NASH cirrhosis, wedged hepatic venous pressure maybe does not estimate the portal venous pressure as accurately as in alcohol and HCV-related cirrhosis. And this could be an important factor to consider in the future. Dr. Chang already mentioned that with the advances we're making with endoscopy and endoscopic ultrasound, the liver evaluation really can become a one-stop shop situation. And we're going to hopefully see a great example of that today and the live case. But in conclusion, I would like to say that EUS portal pressure gradient measurement provides direct measurement of both hepatic and portal veins. HVPG, we know, is not accurate in pre-sinusoidal portal hypertension, and in NASH cirrhosis, HVPG may underestimate the true portal venous pressure. And EUS-PPG is really becoming more accessible. So many endosonographers are picking this up. There's a commercially available device, and it's very, technically quite easy to learn for an experienced endosonographer. And so this one-stop shop option for endohepatology also offers an efficient workup for the patient, and potentially could have some cost savings as well. And with that, I'll conclude. Thanks very much.
Thanks, Jason. That was fantastic, and really amazing, work you're doing. Really pioneering in this area of endohepatology, and it's just a pleasure to see how you're able to extend into all these different areas and really get the subcategories we need to do. So we'll have time, I think, later on to ask questions, or also when you're here at the meeting. I'm going to keep on the theme of portal hypertension.